So talking more about the treatment options for MDS, I'm going to broadly talk about what are the available treatments we have. So before we talk about it, I just want to start with a question, which is very important because this has changed how we treat low risk MDS especially. So this is a patient who is 70-year-old who presented with anemia, had a normal platelet count and normal neutrophil counts. But when they had evaluation done for this anemia, they were found to have this ring sideroblast. These are the bone marrow cells, and you can see that there are this ring around the nucleus, and we call them as ring sideroblast. And they had this mutation called SF3B1. With right now there is an approved treatment for these patients, and that is luspatercept, which has changed how we treat patients with low risk MDS in presence of ring sideroblast. So this is how I treat low risk MDS in 2025. Majority of the times it is determined what blood count abnormality the patient has. If they have a low hemoglobin and they have a genomic abnormality called deletion 5q, I choose something called Revlimid. And if they have a genomic abnormality SF3B1 or ring sideroblast, I go with luspatercept as a first line treatment option. And if they do not have any of these genomic abnormality and the EPO level is less than 200 and they are not heavily transfusion dependent, I go with something called erythropoietin stimulating agents. And if they progress on these, then the next option, which is most recently FDA approved, called imtelostat, a telomerase inhibitor. Once they progress through all these agents, the next option is hypomethylating agents such as azacitidine or decitabine, which is actually FDA approved for high risk MDS. There is a one minor subgroup of low risk MDS patients called hypoplastic MDS. These are the patients who tend to have cytopenias, and their bone marrow is also what we call hypocellular, means less cells in the bone marrow. They tend to respond with immunosuppressive therapy. And as I mentioned, majority of the treatment decisions we make in the low risk MDS is based on the blood count abnormalities. So if they have low platelets, then we go with something called TPO agonist. There are two agents. One is called romiplastim, other is called L-trombopac. And if they have low neutrophil counts, then we choose based on the genomic abnormalities they have. If they have a particular somatic mutation such as IDH1, IDH2, they have a particular inhibitors targeting small molecule inhibitors targeting these mutations. But these are only minor subsets. Majority of patients, if they have neutropenia, end up getting azacitidine or decitabine. And now, briefly talking about high risk MDS, we were fortunate we have so many agents in low risk MDS, but I cannot say the same thing in high risk MDS. We unfortunately are very limited by the treatment options we can offer our patients. And that is the reason why I encourage all my patients with high risk MDS. The first line option is to be participating in clinical trial so that we can develop better drugs for our patients. But if in absence of clinical trial eligibility, some of the treatment options we have is hypomethylating agents. Azacitidine or decitabine could be a good treatment option in terms of improving the blood counts, as well as preventing the progression to acute myeloid leukemia, as well as making them a good candidate for allogeneic stem cell transplant. If they have a somatic mutation, still the IDH inhibitors could be a good option. There was historically a lot of interest in adding something called venetoclax to decitabine. Venetoclax is a BCL2 inhibitor studied well in acute myeloid leukemia. We could potentially utilize that even in high risk MDS. but the phase 3 clinical trial was just reported few months ago, and which was actually a negative clinical trial. But there's a lot of discussion right now ongoing that there might be a subcategory of high risk MDS who might benefit from venetoclax treatment. I think that is still ongoing discussion right now.